Morning, everyone.
Hey, good morning.
Welcome back to our second Instagram live. Hope that everybody made it to where they're going safely. Dr. Wais barely made it to work today.
Yeah, it was a slow drive.
Crazy weather out there. So here we are. Today we are going to talk about a test that is very commonly used in the fertility world, and that is called a sonohysterogram. Almost everybody that has gone through fertility would have done this test or have heard of this test, so we're going to spend a bit of time talking about it, and then of course we're going to answer your questions. So many questions. We might still not be able to get through all of them on our second Instagram live, but we will get to them in the third, so your questions will get answered.
Yes.
All right, so let's start.
So we wanted to talk about a specific test that we do a lot here at Markham Fertility and other fertility clinics as well. It's something called a sonohysterogram. Sometimes we also call it an SHG. Sometimes it also gets called a sono for short because it is kind of a long name. The sonohysterogram is a test that we do as part of the initial workup for somebody who is looking to get pregnant. So what I mean is that if somebody is thinking about freezing their eggs, I don't order it.
That's right.
Or if somebody is looking at using an egg donor, I don't order it. But in a situation where somebody themselves is trying to get pregnant or wants to be pregnant, then that's a test that we would order. So it's a test that we do here in the clinic, just over at Care Imaging on the other side. And it's a bit of a team effort, I guess, between one of the physicians here, so one of the gynecologists, and the ultrasound department. We'll have you come in, usually we do it in the afternoons. We use a little catheter that we put in through the cervix with a speculum exam. And so a speculum is that thing that goes in the vagina to allow us to see the cervix, the medical instrument that we use. Sometimes they're metal, sometimes they're plastic. We use metal, which is actually more comfortable and allows us to see the cervix. And we put the little catheter through the cervix. Do you want to share kind of your experience maybe with the sono?
Yes, I've had a couple of sonos myself. Sometimes they're painful and sometimes they're not. We find that women who have never had a sonohysterogram tend to find it a little bit more painful, and women who've come to us after having had a child or haven't even had a pregnancy, even if unfortunately it didn't result in a child, they tend to find it less painful. So, and that has to do with the uterus already stretching through the pregnancy, that when the sono, it's barely felt. So we can go from zero pain, where patients are literally like, didn't even know you were there, to like a lot of pain.
Yeah.
So we do recommend that patients have Advil prior to coming in, at least 2 pills of Advil. There are some patients who, for other reasons, have a lot of difficulty with exams. That could be vaginismus, that could be a history of trauma, and then we can certainly accommodate that. Sometimes we get anesthesia, sometimes we have other medications like Ativan to help them with that. Generally, the patients are in the room with the ultrasonographer and the gynecologist, and partners are not in the room, but again, there are patients who request the partners to be in the room, and we certainly accommodate that as well. So what we're looking for in a sono is 2 things. We want to look inside the cavity of the uterus, and we also want to look at the fallopian tubes. Now, we aren't always looking at the fallopian tubes. So let's say we're doing a sono prior to an embryo transfer, then we don't need to see the fallopian tubes because the fallopian tubes are not part of the embryo transfer procedure. So if we're seeing somebody with primary infertility or secondary infertility, and we're looking at the big picture and we're considering IUI or IVF, then that's an opportunity to look at the fallopian tubes. So like Dr. Wais was describing, we put a catheter through the cervix, we put some fluid in, and what that is doing is going to open up the walls of the uterus. The walls of the uterus normally are like this, and if you do an ultrasound, basically you're going to see this. It's very difficult to see what's inside. So when you do the sonohysterogram, you're able to open up the walls of the uterus so that you can see on the inside. So we're looking for polyps. Those are very, very common. We're looking for possible submucosal fibroids, or we're looking for abnormal shape of the uterus, it's called a septum. And then if the fallopian tubes are indicated, we also put contrast through the fallopian tubes to see if they're open. What are the risks of the sonohysterogram? So some of the risks the risks are really very minimal. We do so many of them, and the complication rate is very low. But there are patients that are at high risk for infection, and that would be patients that have an ovarian cyst, like endometrioma. So when we see that, we give patients prophylactic antibiotic. That means giving you an antibiotic before you actually have an infection to prevent an infection. And it usually does prevent an infection, but theoretically there is still a risk of infection. So we advise all patients, if they have pain or fever after the procedure, to contact our office.
I think it's also important to talk about what is normal after a sono, and what's not necessarily a sign of a bad outcome or a sign that something went wrong. So after a sono, we're putting a lot of fluid, so sterile saline or the contrast, into the uterus. So it's very normal to have a lot of watery discharge after the sono. Oftentimes there'll be a little bit of blood mixed in it because, we're basically kind of like we're putting the fluid in, we're going to get a little bit of endometrial tissue, like that menstrual, the stuff that comes out during menstruation will also come out oftentimes. And when you have like even a drop of blood and gets mixed in with water, it can look like a lot more blood than it actually is. So that watery discharge, pinkish discharge, a little bit of bleeding is very normal. Some small blood clots can be very, very normal as well, or sort of mucousy, stringy type tissue coming out would also be very, very normal. Cramping. So I often will describe it as, so when the test is actually starting, that's often when people will have the most painful cramps. As the test goes on, it tends to get a bit better. So it starts like, let's say, menstrual cramps, then it will tend to get better. Over the course of the day of the sono, maybe the day after the sono, you might have some ongoing kind of mild menstrual cramps. I think is pretty fair. But again, you can take more Advil and Tylenol, for instance, if you're finding that the cramping is kind of impacting your day-to-day, kind of going about and doing your daily life stuff. But those things are all really, really normal. Probably normal to have that watery discharge for a couple of days, maybe a bit of bleeding, but it should sort of kind of taper off as the days go on.
Absolutely. Another thing that's important to know is the sonohystogram is normally done between day 5 and day 9 of the cycle. So we do this for a number of reasons. First of all, usually by that time there's no more menstrual bleeding, so we don't want that menstrual blood inside, just because it can give sort of confounding information or misleading information. The other reason is we want to do this prior to ovulation. So if we were to do it in the later part of the cycle, ovulation would have happened, sex happened, and then pregnancy could potentially be happening, so we don't want to be disrupting that. So a sonohystogram, because it's done between day 5 and day 9 of the cycle, would not interfere with couples who would want to conceive during the cycle of the sonohystogram. So you can do a sonohystogram in the same cycle that you're trying to conceive, and sometimes we even do sonohistograms in the same cycle as an IUI, as long as you do it early on in the cycle, or in the same cycle as an embryo transfer, as long as you're doing it early on in the cycle as well. As a matter of fact, there is some studies of some evidence that suggests that a sonohystogram have a small increase in pregnancy rate, natural conception, after a sonohystogram over the next 3 cycles. So we do encourage everybody to try the same cycle as a sonohystogram and the subsequent cycles after that.
A question that I get asked a lot, and I'm going to ask you, I'm going to put you on the spot. So after a sono, how long do you tell people to wait before having intercourse?
Yeah, it's a good question.
Because I don't have a good answer. That's why I'm asking you.
I would say 24 to 48 hours. It's probably uncomfortable to have intercourse on the same day as the sono. So, and again, if we're doing it day 5 to day 9, like the ovulation window is not going to start until day 10 to day 16. So I think 24 to 48 hours is reasonable.
Yeah, I think that's pretty fair. I mean, we're not going in and we're not, making massive changes to the cervix or anything. So I think a little bit of time, but that's more sort of for comfort.
That's right.
For the person having the sono than necessarily that having
sex. I don't know that there is a risk. There is no risk really even if having sex on the same day as the sono. And the last question is, how often do we do sonohistograms? So if there is no changes, that means there hasn't been any regular bleeding, there is no pregnancy and miscarriages in between. We normally want the sonohistogram to be like within a year's time. So let's say you're coming from an embryo transfer and you haven't had your sonohistogram in 2 years or 3 years, we're definitely gonna wanna repeat one. If there was a miscarriage and there is a concern for retained products, if there was a pregnancy and let's say there was a C-section or retained placenta or complications from that point of view, anytime there is irregular bleeding or mid-cycle spotting, anytime we see something abnormal on an ultrasound, those are all the reasons to repeat the sonohysterogram earlier than that time.
Another question I think that it's important to talk about is how good is a sono as a test?
That's a great question. Actually.
And I think, I would venture to say that I think it's a question that a lot of us think about as physicians, because any test we're looking at, we're always evaluating, well, how much test of the value, does this test actually have value or not? Like, is it actually answering the question that I want to answer? So I think it's an important question for any test. So with a sonos are really good at looking at the inside of the cavity, right? So again, looking for those polyps, fibroids, scar tissue, the shape of the cavity, etc. That's where, they really, really shine. And so they're, sensitive and specific. So those are the terms that we use when we talk about tests. So that's great. When it comes to looking at the fallopian tubes, it's still a good test, not as good as for looking at the cavity. And, I think a lot of it so when I'm doing a sono on, let's say, one tube, I can't see the contrast spilling out of the tube. I never say that tube is blocked.
Correct, yes.
I'll always say, I can't prove that the tube is open. And so it's subtle, but what I'm trying to get across is this idea that even though, I can't prove that the tube is open, but it could very well still be open. Sometimes, we just can't see things very well in ultrasound because of, where the ovary is or where the tube is located, that it kind of dives deep, sort of, let's say, behind the uterus. And so the visibility is not as good, or there's lots of a really active bowel around there. It's making it difficult to sort of see where things are, or a lot of bowel, gas in the bowel that sort of creates this shadowing that kind of, it's really like you're looking deep into the shadows, essentially.
That's right.
It makes it really, really tricky to see. And then we also know that the tubes can sometimes go into spasm because they're lined by muscle, just like, you can have a spasm in your hamstring or something like that. Your tube can go into spasm, and it's a temporary thing. But it will look as if the tube is blocked, but it doesn't necessarily mean that it is blocked.
Absolutely.
And so that's kind of the challenge. So I'm going to put you on the spot again. So, okay, let's say a patient has a sono and the cavity looks okay, and then maybe one tube, you can't prove that it's open, but, they don't really have any risk factors for a blocked tube. How do you counsel around that, or what do you do with that?
Yeah, exactly as you say. If one tube is open, and basically we look at the whole picture. So let's say this couple is young, they were really hoping to do IUI, it's the right treatment for them, and doing the sono to confirm that, IUI, that there is no risk factors for IUI. And if one tube is open and the other one cannot be seen, again, doesn't mean it's not blocked, but cannot be seen on sono, then I would still advise to proceed with the IUI. Number one, because how do I go about finding out if that tube really is open or closed? It's doing a laparoscopy. A laparoscopy is an invasive procedure, it's a surgical procedure, there's a long waiting list. And I don't know that your return of investment is that great in going through a laparoscopy just to see if one of the two fallopian tubes is open or not, that you couldn't see at sono. We know that even if it was blocked, even if we can prove that it was blocked, one open fallopian tube can still lead to successful pregnancies with IUI from either ovary, actually. But sometimes because IUI, there's a cost as well. We might say, well, let's only do the IUI if the follicle is on the ovary that has the proven open fallopian tube, and if not, then we'll just do time intercourse. Just because of the cost of the IUI, not because we think that there is zero chance of IUI working if the follicle is in the contralateral ovary.
And I think that's worth repeating. Even if you have your big follicle, your dominant follicle, let's say, is on this side, but this tube, we can't prove that it's open, can still get picked up by the tube on the other side, and there's still lots of pregnancies that happen like that.
Absolutely,
and so that's something that's really, really important.
There's a question here from Crystal from Fertility Bloom. Hi, Crystal. Question for a client. How long after an ectopic can you do sono to check on the tube, and can you see from that if the tube is okay? That's a great question. So ectopic is a really good reason to do a sono prior to restarting fertility treatment as well. I would say we want to make sure the pregnancy test, like the beta ECG, is back to 0 for whatever treatment the ectopic was, whether it was surgical or medical treatment. So we want to make sure the ECG is back to 0. Ideally, 1 menstrual cycle has taken place. And then a sonohysterogram would be a great test to look inside the cavity of the uterus, but specifically to look at the fallopian tube. And again, if we see that there is flow going through that fallopian tube, then we say the tube is open. And if there is no flow going through the fallopian tube, then it means, again, it could be that it's not open, and now there is a clinical history. It's very different from when you said there was no risk factor. Now there is a risk factor for a potential blocked fallopian tube, so that's something to be taken into consideration. Another thing that we didn't mention is the opposite. So we're saying when we don't see flow through the fallopian tube could still be open. Well, can you see flow through the fallopian tube? And the fallopian tube is essentially not functional, and that can also be a situation. So sometimes fallopian tubes can be there is flow through, but they could be scarred down. There could be an adhesion of the fallopian tube against the wall of the uterus. They could be swollen, and even though you see flow through it, at the time of laparoscopy, which is the only way to really look at the fallopian tube, they might not be functional. Yeah. So that's something to consider as well. But to answer Crystal's excellent question, I would say once the ECG level is back to 0 and there is 1 menstrual cycle, and yes, if we see flow through a fallopian tube after the ectopic, then that's reassuring that the fallopian tube is back to working.
Yeah. I always like to tell people, the fallopian tube is a lot more than just a pipe, right? Like, it's not just plumbing. The tube has a lot of roles in terms of helping an early pregnancy, getting the sperm and the egg together. Unfortunately, the sono is kind of like the best test we have of tube function. And so we're looking at one function of maybe like countless functions that we don't even understand fully. So it's important to know that the tube is open, but it doesn't necessarily mean that the tube is functioning normally. Or that it's doing all the things that it's supposed to do, because it's more than just a pipe.
That's right. All right. So that's a lot on sonos. We spent 20 minutes talking about the sono.
Yeah. Well, it's a really big test.
It's a really big test. And everybody, and almost everyone that's going through fertility is going to be doing it. So certainly worth talking about. So now we're going to start answering the questions. We have 32 questions. We can get through all of them. All right, so the first question is, can you explain the surrogacy process? Now I'm going to put you on the spot. See? Go for it.
Okay, so when we're talking about surrogacy, so technically, I guess, the appropriate term is a gestational carrier, which distinguishes it from a traditional surrogate. And there's sort of nuance in sort of what the terms mean. But basically, we're talking about another person with a uterus carrying the pregnancy, let's say for somebody who for some reason cannot, whether it's because of medical issues that prevents them from being pregnant, whether it's because they don't have a uterus, let's say, because they weren't born with a uterus, or because they had to have some sort of surgery on the uterus, or even patients who have, let's say, recurrent implantation failure, where we've done all the things and nothing has worked, or recurrent pregnancy loss, again, where we've done all the things and it hasn't worked. And so they're going to be using another person to carry the pregnancy, who would be the gestational carrier, or the GC for short. So the process, so once, let's say somebody is talking to their fertility doctor right now, they're sort of thinking about, maybe moving on and sort of thinking about a gestational carrier. It's a bit of a complicated process, and it's a long process. So this is really in the Canadian context, and I think that's a really, really important distinction to make. We practice in Canada, so we sort of know what happens in Canada way better than we know what happens in the US and internationally. So in Canada, we have this federal law, it's called the Assisted Human Reproduction Act, where it is illegal to pay somebody for their eggs, their sperm, or to be a gestational carrier. So being a GC or surrogacy is done, has to be done for altruistic means. So somebody is doing it because they want to do it out of the goodness of their heart. So that's really important. So let's say somebody is thinking about a GC. First question we always ask is, okay, well, do you have somebody in your life who would potentially be willing, or that you could talk to about this? Because if there's already that connection, then that makes things a lot easier and a lot simpler. The vast majority of patients, I would say, don't have anyone. And so then they might be looking at being matched with a surrogate. So oftentimes we work with agencies. So we will refer our patients to agencies who help match them with potential gestational carriers or GCs in the community. Because of various factors, including kind of that law that I spoke about, the number of potential gestational carriers in Canada generally is a lot lower than it is in the US. And so generally it's a much longer process in Canada than the US, and much more expensive process in Canada than in the US from what I've heard. Mm-hmm. And so, that is sort of something, a very, very important distinction. So, to give an idea, I mean, I've heard of patients sort of waiting a year and a half, 2 years to be matched with a gestational carrier. Now, again, I've also had patients who've gone and done like big ad campaigns, like post on Facebook and social media, and told their story and done like a whole thing, and they've had success with that as well. But it is definitely it is a difficult process, and it is definitely not the easy way out by any stretch.
Yeah, and the costs really vary because it really depends. I mean, there's a cost of paying an agency, there's a cost of the expenses to the surrogate, so that would be traveling, and food, and clothing, and parking, and gas.
And that can vary a lot,
right?
Because you might be matched with a surrogate who lives, down the highway, or you could be working with a surrogate who's in a different province. And
then there is also legal costs as well, because having a legal contract is really important, and that's something we can sort of talk about more another time about the legalities of all of that. The last thing I want to say about surrogacy is, the ideal surrogate would be somebody who's had a prior pregnancy, of course a prior uncomplicated pregnancy, and whether it's her own or a surrogacy journey. So we certainly wouldn't want to use a surrogate that has never been pregnant before, because you just don't know what that is going to be like. The more C-sections somebody has, the higher the risk for both mother and baby, but specifically for gestational carriers. So we want to have at least, less than 3 C-sections ideally, just because the risks go up significantly after that. And we want them not to be fairly young, about 40 years of age or younger. Again, the risk of pregnancy complications go up as you get older, even if, especially if you're carrying as a gestational carrier. And so those are some of the things that we think about when we are approving a surrogate. The first thing, if you are matched with a surrogate, is to let, and you're a patient of MSC, is to let our donor and surrogacy team know, and then our physicians will review the history and decide whether this is a surrogate we can work with or not. And then from there, she will undergo the investigations, and then from there, you do the legal contract once your physician has given her full clearance. All right, so the next question is about the Emma-Alice test. The question is asking, what are your thoughts on the Emma-Alice test, and does it make a difference in IVF outcomes?
Yeah, good question.
So let's talk about what it is. So the Emma-Alice test is a biopsy. It's a biopsy of the uterus that is normally done in the luteal phase. What this biopsy is looking for is for bacteria, and there are 2 types of bacteria. There is a bacteria that can cause chronic endometritis, that's a pathogenic bacteria, and there is bacteria that normally lives in the uterus but at a very low amount, and sometimes it can be overgrown. It's also looking at the lactobacillus, which is a healthy type of bacteria that you want to make sure is present in the uterus. So that's what the Emma-Alice test is all about. Does it really make a difference in IVF outcomes? Because that's $1 million question, and the jury is still out.
Yeah.
The ideal study would be randomizing patients before their first embryo transfer into having an Emma-Alice test or not, and then transferring without unblinding those results, so without anybody knowing what the results are, and then seeing if there is a difference in pregnancy outcomes for those that were positive or negatives for the Emma-Alice. That study hasn't been done, which is why we have a hard time recommending Emma-Alice tests for people that have never had an embryo transfer and have never failed an embryo transfer before. Now, once you've gone through IVF, and especially if you have euploid embryos and you fail multiple euploid embryo transfer, then it becomes a question of what is going on? We know that a euploid embryo transfer has about a 70% pregnancy rate. So when you fail 2 or 3 of those, we start thinking, what else is happening here. And that's when we start thinking about the MLE test and the immune testing and some other things. So at this point, we are recommending it for patients with recurrent implantation failure after a discussion of the fact that there isn't really a lot of evidence yet to recommend it, widely. And the jury is still out as to whether or not it really improves IVF outcomes in the general IVF population.
Yeah, I think that's a really good summary of the test. I think that in the world of fertility, there's a lot of companies out there who make tests and put them to market so that they're commercially available, like you can pay for them, you can get them done before there are good studies that are published, which it's kind of like putting the cart before the horse. And it's something that's really unique to the world of fertility.
That's right.
Like, if you're a cardiologist, I've never heard of that when I've spoken to other specialists that, you make a test and then they kind of figure out the research afterwards, but that is the situation.
Yeah. And I mean, the next question is about the ERA. The ERA stands for endometrial receptivity test, and it fits in perfectly because the ERA is a cautionary tale of what Dr. Wais just mentioned. So the ERA is also an endometrial biopsy that was thought to be really crucial in improving pregnancy rates. So it's basically doing a biopsy of the lining of the uterus to see when is the best window of receptivity is. So when it first came to market, it was widely used. We certainly did lots of ERAs because we really want our patients to conceive, and we want to make sure that we give them every opportunity to do that. And then there was a really big study done looking at the ERA. It was actually done by the group that was developing the ERA, so good for them. And that study actually showed that it did not have the benefits that we thought that it did. So when they actually compared people that had ERA and didn't have ERAs, and they were able to do like a proper study, it showed that there was no evidence no improvement in pregnancy rate between doing an ERA and not doing an ERA. And actually the group that had an ERA did a little bit worse in terms of pregnancy rates than the group that didn't have an ERA. So from that, the ERA is done much less than it was done before. I don't recommend it as much as I did before, but that sort of teaches you a lesson that sometimes, fertility patients, rightly so, are desperate to get everything that they can to improve their outcomes, and fertility doctors, that's what I was gonna say, and fertility doctors are also very much desperate in trying to get those outcomes for the patients. So I certainly get it from both sides. My own my own anxiety and my own desperation and my own desire to get my patients succeed, and also the patients saying, I want to do everything, even if it's so. It is sort of a tricky situation, and our job is to make sure that we're looking at both things: the patient's desires and also the evidence. So sometimes patients tell me, Dr. Garcia, I trust you, I believe you, I understand what you're saying, I still want to do an ERA, or I still want to do an MLE test, even though it's my first embryo transfer, because I just need to know that I've done everything. And then we do it because it's all about patient autonomy and informed consent.
Oh yeah, absolutely. I think it's important to say, even though we may not sound like the biggest proponents, let's say, of it, we still do it all the time, to be totally clear. Yeah, absolutely.
Let me have a look here. So one of the questions is there a fee at MSC for having an Emma Alice conducted? Well, it's not an MFC fee, it's an Emma Alice fee. So we have to take that biopsy and send it to Egenomics, and they have to process it and give us the results. So that's where there is a fee for that.
Yeah, because it's a test that's not covered.
It's not covered by OHIP.
Under OHIP, and that's something that you're paying the private company.
That's the one,
we got another question. So it says, is there any evidence of IVF increasing risk of any other diseases? And so, the short answer is that for the person who's actually undergoing the IVF, meaning the stimulation, the retrieval, there's no known increased risk of diseases for that person over the long term. There are complications that can be associated with IVF, and there are side effects associated with IVF, but they are time limited and short, and the complications are extremely rare, but there's actually no known increased risk of diseases for a person from doing IVF itself.
Right. The next question is, what are some options for low sperm count?
This is a great question.
So this is a great question, and I mean, we can talk about sperm for a while, but
I mean that's a whole
that's a whole thing,
topic in and of itself.
Right. But let's talk about low sperm count in particularly. So unfortunately, there is no evidence-based single medication that you can give and say, take this, 3 months later your sperm count is gonna come back up. That just doesn't exist, unfortunately. Now, there's a few things that we can do. So first of all, the first thing is, let's remember a low sperm count. Like, what is a low sperm count? So the normal sperm count that we want is 15 million. We are also looking at the motility. So let's say you have like 14 million sperm, but a motility of 56%. That is almost a normal semen analysis. So you can have a low sperm count that is like 10 to 14 million, or you can have a low sperm count that is like 1 million or 0.5 million. So you gotta think about, how low is this low sperm count? So if the sperm count is a little bit low, I always tell patients pregnancy can still happen. And I always say it is like getting, report back, getting a B+ in your math test or whatever. Like, it doesn't mean that you're a bad student or that you don't have potential or anything. It's just one test. So it's really it's really not a reason to say, oh, that's it, I got a bad test and I'm never gonna be pregnant and I need to do something else. So that's that. The second thing is, even though there's no medications, there's some lifestyle factors that can improve sperm count. That would be avoid hot tubs, saunas, jacuzzis, anything that is excessive heat to the scrotum. Also, smoking, drugs, and alcohol, those things can definitely have an impact on sperm motility. Just like for women, lifestyle is important. Exercise, nutrition, hydration, and sort of maintaining a healthy weight is also important. And then there's supplements that you can take to improve the sperm count. We have the Burton B supplements here at the clinic, or also Filter Pro. And generally, we're looking at zinc, magnesium, CoQ10, selenium. Those are some of the things that have been shown to improve sperm count and as well as motility.
Another one worth mentioning about sperm, I'd say, is that a whole new cohort of sperm is produced every 3 months. So if you're going to do something, you have to do it for, minimum 3 months to be able to see any kind of effect. And that if something happened in the 3 months leading up to the sperm test, it can have a significant effect on the semen analysis. What I mean is, like, let's say one that we used to see a lot was like men who got COVID. Right. A guy who got COVID and had a fever for several days, let's say, that in and of itself would be enough to really sort of tank the sperm count, but it would bounce back once we sort of got over that kind of 3 month window. So any kind of illnesses in the past 3 months are a big one. Another one I wanted to mention, just because I'm seeing more and more of it, is men who are taking testosterone replacement therapy, TRT, and men who are taking some kind of anabolic steroids.
Right, absolutely.
So, testosterone replacement therapy, anabolic steroids are terrible for sperm. Like, you can take a man who may have had a normal semen analysis and it will go to zero, like absolutely no sperm whatsoever. And when you stop these things, the sperm may come back.
Takes a long time.
Takes a very, very long time to come back. And it may not ever come back in the same way, meaning that, you may have had a normal sperm test, but now maybe you're sort of have like a not stellar sperm test, and now maybe you need IVF for that reason.
That's right.
So testosterone replacement therapy, anabolic steroid use, they're increasingly common, I think. But they have a huge impact on sperm.
That's
so
right.
I think that's something that's really, really important. For some reason, which I don't know, I hear a lot that patients think, oh, if I take testosterone, my sperm is going to get better.
Yes.
That is absolutely not true. Like, just not true. And there's a big, long reason explanation for that, but I won't get into it. But I just want to sort of point that one out.
Absolutely. The next question is, once pregnant, what happens? When did you graduate from the clinic? So once
first of all, yay. You're pregnant. That's awesome.
So once you're pregnant, we'll continue to monitor you in the first trimester. So you'll come for your first viability ultrasound about 6 to 7 weeks, and then usually again at 9 weeks, and then the last one would be around 12 weeks. And that is the one where we do the nuchal translucency test, which is an important part of looking at the health of the pregnancy, and also offer you prenatal testing options. That could be the HIP-funded first trimester screen, or it could be the non-HIP-funded non-invasive prenatal testing. You normally graduate from the clinic at 12 weeks, so as soon as you get your first viability ultrasound, we highly encourage you to look for an OB. We take care of referring you to an OB, so you can either say, hey, I want to stay in Markham, please, doctors refer me to anybody in Markham. Everyone here in our department is amazing. Or if you are not from the Markham area and you want to be referred back to your community, you just have to give us a name and we'll take care of the referral. We want to do that really early, like as soon as your first viability ultrasound, which is 6 to 7 weeks, because it's hard to get in with an OB or a midwife. So the sooner that we can send a referral, the better. Just because we send the referral at 7 weeks doesn't mean that you're being discharged from our practice at 7 weeks. And I think a lot of patients are very worried about being referred out so early. We do want to take care of you during the first trimester because, unfortunately, as you know, there could be issues in the first trimester, miscarriages or not, and we can help you manage that. So just because we're making the referral doesn't mean that you're completely being discharged. Usually, the referral gets made, and then your appointment with the OB, it's going to be sometime after the 12-week mark. So it's at that point, after the 12-week mark, you pass the first trimester, you've done all of your prenatal testing, everything looks great, that you will be seeing your OB and you're officially discharged from the clinic. Another thing noting is that when you graduate, we give you a little baby gift. It's one of those little onesies. Oh, wait, do you have one here?
No, I took pictures of there, yeah, sorry.
Oh, you have it in your drawer, no?
No,
not anymore.
Sorry.
Okay. It's one of those little baby onesies that you might have seen in social media, and that's our graduation present to you. So that we send all the information to the OB. We also send a letter to your family doctor to let them know that you are now pregnant, discharged from our practice after the 12 weeks, and that we have made arrangements for OB or midwifery care.
And I think one thing I just want to highlight is, yes, we need to get those referrals in early, because many midwives, OBs, family doctors practicing obstetrical care, they have caps. Like they will only have a certain number of patients that they're going to see who are delivering in a specific month. And once they hit that cap, like they're not seeing anymore.
That's right.
So your referral can absolutely get rejected. I mean, I think I've had some patients where oh my God, I think we've gotten them rejected like 3 times before.
We found somebody,
before we actually found someone who could take them on, because we had, sort of done the referrals later on. So we're not trying to push you out of the clinic by any stretch. We just want to make sure that we get you to the provider who's at the top of your list. That's really where it comes from, because we don't want you to be disappointed. We want you to have, the pregnancy care and the pregnancy journey that you want to have.
And it's always, I mean, it's so interesting, because obviously patients don't really want to be at a fertility clinic. But when that time comes and they graduate, they always say the same thing. It's like, I don't want to leave.
Oh yeah.
And I say, but this is what you were waiting for. This is the moment.
This is the whole point.
It's like, no, I don't want to go. So there is certainly this feeling. So if you're feeling that, that's completely normal. And we totally get it. We also kind of feel like, hey, I don't want to let you go either, but we have to go and help other people get pregnant as well.
I actually do kind of encourage people to go, only because I know that OB providers and midwives are going to do so much better care when it comes to prenatal care than I do, because I just don't do it very often. And so I just want to make sure that you're in the best hands possible. So once you're in that second trimester, somebody else is much better at figuring out things like gestational diabetes than me.
Exactly. But there's definitely mixed emotions. That's for sure. All right, so while Dr. Wais looks, I'm going to take the next question. So what are the potential benefits of low-dose IVF or mini IVF? So at MFC, we love mini IVF.
Yes.
Right? We do. So what is it? So it's standard IVF is when we use standard dose of medication. That's usually anywhere between 300 to 450 international units of whatever gonadotropin we're using. A gonadotropin is those expensive injections that you use for IVF. they sound like Piragon or Gonalef or Menapure or Recobel. So a mini low dose IVF is basically using a low dose of those medications. That low dose could be anywhere between 75 to 150 in that range.
Yep.
Now, when we do IVF, the goal is to get as many eggs as possible. So if we have somebody that have good ovarian reserve, and we know that by giving a standard dose of medication, we can get 15 to 20 eggs, we definitely want to do that. So that would be somebody where standard dose IVF is best, because you know based on the ovarian reserve that you can get a good 15 to 20 eggs. And that is the ideal situation, especially if it's your first IVF cycle. Now, there are patients that have low ovarian reserve, and you know that no matter what dose of medication they get, they're only going to be getting about 1 to 2 eggs or 3 eggs. Sometimes clinicians would give very high dose to those patients with the thought of like, okay, they don't have a lot of eggs. I have to give high dose to drive those ovaries to even make that 1 or 2 or 3 eggs. And there's nothing wrong with that. We can certainly have done that in some situations. But in those patients, after the high dose of IVF hasn't been successful in either creating euploid embryos or in stimulating the ovaries, sometimes the opposite can be true. So a low dose IVF can actually provide a better response to ovarian stimulation in those situations. So the other benefit of a low dose IVF is a lower cost as well. So when I have patients that come to me for a second opinion, they've done a high dose IVF, they have low ovarian reserve, they're only getting 2 to 3 eggs. I many times would suggest a low dose with the idea that sometimes those FSH receptors, which are the receptors that are getting the medication to develop the eggs, sometimes they get saturated by the very high dose of FSH. So I would suggest a low dose, because we're saying, okay, we know with a high dose, you're still only getting 2 or 3 eggs. So might as well give you a low dose, get the same 2 or 3 eggs for about half the cost or a third of the cost. And sometimes you actually get a better response and better quality of those eggs just by using a low dose IVF. Another reason to use a low dose IVF is less common, but certainly can be a situation. There are patients that for religious reasons, they cannot have an excess of embryos, and they want to make sure that they are using every single embryo that they make. If those patients happen to have really good ovarian reserve and there's a concern that I'm going to make a lot of embryos for them that they ethically don't feel comfortable with, then we would use a low dose IVF so that they're not getting a lot of eggs and therefore not a lot of embryos, or more than their wish for their own ethical reasons. But the most common reason to use a low dose IVF would be that first situation that I described of the low ovarian reserve.
Yeah. I've also used it in patients before who maybe have a good egg reserve, but who have poor egg quality, where you get a lot of eggs, but you don't get many embryos or not great embryos. I don't know, in my mind, I think about it as like those injectable medications are driving the ovary to make the eggs, and sometimes less is more.
That's right.
And you can get better egg quality for sure. The other thing is, I've also heard low dose IVF called so many different things, like mini IVF, low dose IVF. Sometimes even people call it like more natural IVF, which
modified natural
IVF.
Yeah.
But it's all kind of like, there's no standard name or standard term, but they all kind of refer to the same thing probably.
Absolutely.
Yeah, so I think we should wrap up soon. I don't know if we want to answer one of the questions maybe that somebody asked on here. So I'm just scrolling through. Okay. Okay, so after a first failed FET transfer, how do you decide if you need to change the next protocol or keep it the same? Okay, so this really depends on how the first FET went, first of all, and sort of what your general fertility history, infertility history of IVFs is. So for instance, if somebody was, let's say, in that first FET, let's say you were transferring, a poor quality embryo, or it was a day 7 embryo, or it was a genetically untested embryo, then, you may not end up changing the protocol actually, because you may feel like that it was really a function of the embryo and not necessarily protocol in terms of why somebody get pregnant. We know that, depending on the age of the person producing the eggs or when the eggs were produced, if it's somebody in their 40s and you have an untested embryo, the chance of it working could be I don't know, 20%, right? So that's not really a function of protocol. That's a function of the embryo. So that might be it. Another reason why we may change the protocol is in terms of patient preference, patient comfort. So what I mean is that, you know, we have natural cycles, we have medicated cycles, there's pros and cons to each. But let's say somebody who is traveling from really far, they may want to, a goal of theirs might be to try and minimize the number of appointments that they have. So that might sort of change the type of protocol that we do, let's say. Or let's say while we're doing the protocol, we find that you know, we tried a natural cycle, but maybe it takes them a really long time to ovulate.
That's right.
Then maybe we'll change it up just to sort of, again, for not necessarily to get a better outcome, but for convenience and sort of keeping things more reasonable for the patient and reducing stress, which I think is important too.
Absolutely.
And I'm sure that plays a role as well.
And also look at the progesterone, how they tolerated it.
Yes, that's a big one. It's a really big one. Because changing the type of progesterone, if somebody had had allergic reactions to it, or if somebody, you know, was not tolerating progesterone injections, we would change it up. So that's a really long-winded way to not really give you a very specific answer.
And you also have to look at, you know, what other embryos you have available. So if you did the first embryo transfer and you still have 4 euploid embryos available, and again, it's the reason it was a runabout question, because it's really, there's so many things that go into it. So like Dr. Wais says, look at everything that happened in that protocol. How was the lining? How did the patient feel? How did the blood work look? How did everything look? What kind of embryo it was? And then look at what's next in terms of how many more embryos you have available, and make a decision from that based on the patient's preference and where they are on the journey, and recommendations and all of the things.
I will say, I do feel like, in general, the most important factor in the embryo transfer is the embryo.
Absolutely.
And so even when we don't change the protocol, we're not changing nothing, right? It's a whole different embryo. And that is a huge difference, and that's actually a huge change. So even if the protocol stays the same, your transfer is going to be totally different because it's a different embryo. And I think, you know, in general, the embryo is still, like, by far the most important factor and the most important thing, and still a bit of a black box. Yeah.
I had about 8 embryo transfers, and I think 5 of them were exactly the same protocol. So I mean, absolutely.
Okay. What size of subserosal fibroid do you recommend removal, and can they be removed during C-section? Again, that's a really good question around fibroids, but I think, you know, to be honest, like, that really depends on the situation, in terms of whether that fibroid's causing you issues or not, in terms of symptoms, like unrelated potentially to fertility. Can they be removed during a C-section? Yes and no.
Yes and no.
Depends on who you ask. It depends on the size of the fibroid. It depends on the C-section too. So if you're having an emergency C-section at 3 a.m., I really don't think anyone's going to be removing your fibroid. If it's an elective C-section that's done during the day with a lot of people around who are planned C-section, where there's a lot of people available to help in case there's any issues, then there's a higher likelihood that somebody would do it. But generally speaking, subserosal fibroids, meaning a fibroid that's on the outside of the uterus, so sort of like attached onto, or kind of like glued onto the uterus, generally are not thought to affect fertility, implantation rates, embryo transfer pregnancy rates, or miscarriage rates. So I don't actually very often recommend removal of subserosal fibroids.
It's usually only, like, I mean, sometimes a subserosal fibroid can, like you said, not impact any of that, but then it could prevent, like, the baby from descending, depending if it's,
obstetrical stuff,
obstetrical issues, but definitely not from the fertility point of view. But sometimes it can cause symptoms to the patient, pressure, bladder issues, you know, constipation because of the location and the size, or
even just like a tangible bump, like just in your stomach, right? And those are all fair reasons.
What can someone do better for second FET after first being successful but ended in miscarriage? Miscarriages are not the patient's fault, and I think this is very, very important. I wouldn't say what can you do better, but certainly what can you do in general, because I think that question of better puts the blame on the person, like it didn't work the first time because you didn't do all the things. And I want to make sure that we steer away from that. I think it's really important to know that miscarriages are nobody's fault, and that sometimes even euploid embryos can end in miscarriage. So what can you do next time is a lot of times similar to the things that you might have done the first time, which is take your prenatal vitamin, your vitamin D, make sure that you get a checkup with your REI, get your sono done, talk to your REI about the kind of embryo that is being transferred, take your progesterone on time, all of the things that I'm quite sure you probably did the first time. Okay, all right. Well, thank you for the nice comments. Somebody said, love that you are doing this. Thank you both. Great, we're gonna keep doing them. So we'll be here again on Tuesday at 9 a.m. Next week, and every week after that is it when we're on vacation. Because we're still taking vacation, right?
Oh my God, yes. I don't deal well with winter or the snow or cold.
All right, everyone, have a wonderful day and drive safe, stay warm. We love you. Take care. You've got this. Bye.
Bye, guys.